Dr. Dean McEwen discusses congenital hip problems. The problem of stability of the hip in the growing child has been with us for a long time. Would you bring us up to date, Dean, on the current approach to congenital hip disease?
In years past, the interest was particularly in whether or not the hip was reduced, and the primary treatment was of the greatest interest to the orthopedist. As time has gone along, we've realized that the problem of residual dysplasia and subluxation is very, very important. Also, in recent years, the evaluation of the newborn and the young child has taken precedent over the older child in many places and conditions. And therefore, there's been an entirely different approach to the treatment of CDH in the past number of years. In the older child, the problem is that to obtain not only a reduction, but as complete a reduction as possible in an effort to prevent osteoarthritis of the hip. And if this can be obtained, then probably at best, if the child has been treated after walking age, the hope is for a delay in the onset of osteoarthritis than the prevention. And therefore, all treatment programs should be tempered to some degree in an effort to obtain a good result, but maybe not possibly a perfect result. This is a child of 16 who was treated at 12 months of age for a congenital hip that has a very satisfactory result. However, here is a relatively simple problem that was reduced by closed methods, but ended up with a hip that's definitely subluxated and not doing well in the middle part of childhood, and is destined to have a bad result at this time, no matter what is subsequently done. Even an open reduction, if in the early years of life, can end up with less than an ideal result. This is a patient with a hip that's only partially reduced, but also on a similar problem on both sides. And in many ways, this patient will have problems sooner than if the hips had never been reduced at all. So the idea is that the hip should be reduced, but as completely as possible. For many years, closed reduction was the method of choice, and then there was a great interest in open reductions. Probably in most people's hands, it is better to reduce the hip by closed methods, if at all possible, up to 2.5 to 3 years of age. This is because, in this day and age, no one individual surgeon has a great opportunity to obtain a large experience on open reductions of the hip. So if a simple closed reduction is possible after traction and without force, probably this is the best method for most people. The thought was that if open reduction was accomplished, that there would be no longer need for further treatment. However, in our analysis, it showed that even after an open reduction, 33% still required some type of secondary procedure. However, in the closed reduction, 66%, approximately twice as many, required a secondary procedure. However, with a secondary procedure after the closed reduction, the final result was essentially the same as whether an open reduction had been done. So I believe at the present that in most people's hands who have not had a large experience in the open reductions of congenital dislocation of the hip, that if a closed reduction can be done, even with the anticipation of a secondary extra-articular procedure, that this is the most desirable. Some other things have happened in the past number of years that have changed the trends in treatment of congenital hip. One has been the interest again in femoral shortening. This was a procedure developed in the 20s in Europe that has recently been rediscovered and thought about again. One of its prime indications is in a child that's had a previous open reduction that's failed. It is very difficult with traction to pull the hip back down after a previous surgical intervention, and a femoral shortening during the subsequent open reduction has kept the tension off the hip and produced a hip that will move more freely. So the idea of a femoral shortening should be considered in the older child and in the child with a complex hip. However, this adds extra procedures, extra fragments that need to be stabilized, and so for the child that can be treated in a simpler method, this method should probably still be avoided if possible. In any child that's had a reduction by open or closed methods after walking age, there will be secondary problems that will exist. The condition to be feared is not dysplasia, but that of subluxation, where there is lateral displacement of the femoral head from within the acetabulum that has either never been deeply placed within the acetabulum or has subsequently migrated laterally to some degree. This should not be tolerated at any stage. On a particularly bad day, a redislocation will occur, but this is very obvious and very easy to determine on the average. So the big discrepancy is whether or not there's a residual dysplasia, which is to be expected, or whether there's a residual subluxation, which should not be tolerated. An example of these can be a patient like this. Here's one that had a reduction at approximately a year of age. At age 2, there is a residual acetabular bony change. By age 6, it's apparent that there's been some improvement in the alignment. And by age 13, when the child is essentially mature, there is close to a normal alignment of the proximal femur and the acetabulum. It is not perfect, but probably at this stage it's better to tolerate this minor imperfection than to carry out a surgical procedure. However, in this patient who started out looking even better after a reduction, by age 12 it's apparent that the acetabular roof has not continued to grow and cup the femoral head. And this patient had nothing done, and by age 26 it's apparent that at least half the femoral head is not covered by the acetabulum. It would have been much better to have carried out some type of procedure in the earlier stages while the child was still growing to prevent this result at age 26, because something could have been done to augment the acetabulum and probably contain the femoral head somewhat better during the growing stages. It is difficult at times to tell between a subluxation and a dysplasia. Here it's rather obvious that the femoral head is displaced somewhat laterally, and the advantage of an arthrogram can be determined at this time, in that an arthrogram can show whether or not there's pooling of the dye medially. However, in many of these children where it's borderline and where the condition is unilateral, there's some advantage of carrying out an arthrogram on both hips to determine what is a more normal appearance on the opposite side, because even at best there's a little tendency to pooling medially, and it's probably best to have something to compare it to where at all possible. For the child that's felt to have only a dysplasia but is not recovering in the sense that the femoral head is not ossifying in the regular way, probably they can be left several years as long as the condition is improving. And in a female, probably up to age 8, and in a male up to about age 10, can allow a natural history to go on to see how much it will improve by itself rather than intervening surgically. If the hip is not at a proper stage by this time, then one should consider one of the procedures that will be considered for subluxation. But the dysplasia can be tolerated for several years, long as one is certain that there's not an associated subluxation at the time. A subluxation, however, should have treatment as soon as this can be recognized. If it occurs early in years, when the child is quite young, up to approximately 3 or 3.5 years of age, one can consider an abduction brace to maintain the femoral head deeply within the acetabulum. One should obtain a standing x-ray to be certain that the femoral head is well seated. And in this condition, in these young children, probably 50% will recover spontaneously without the need for surgery. But the subluxation should not be left unattended. It should either have bracing treatment or some type of surgical consideration. Dr. Salter's procedure with the osteotomy through the pelvis to rotate the acetabulum anterior and lateral over the femoral head has an excellent consideration for a child that has a mild subluxation or a dysplasia that is not responding. And in this condition, the femoral head can be cupped deeply within the acetabulum. It has one drawback: if the displacement is too great, and it can produce an increased length of the pelvis on that side, which is undesirable, and therefore the fragment should not open posteriorly, but if possible even being a closing wedge. The other problem with this procedure in the young child has been that if the pins are not placed correctly, that the distal fragment can migrate medially and produce an unsatisfactory result. It's most important that the pins be placed in the proper position down along the medial side of the acetabulum, and also that this position be confirmed by X-ray before the child leaves the operating room. With these constraints, the procedure works very well and is ideal for residual dysplasia or a mild subluxation. Dr. Pemberton's procedure, in which the acetabular roof is deformed through the triradiate cartilage, has been very helpful, particularly for the subluxation that is a result of a lateral gradual migration of the femoral head, where the acetabulum has opened up, so to speak, and is larger than would be anticipated. And in this condition, if the acetabular roof can be bent down to reproduce a more normal contour, then with any good fortune, one can anticipate a good result. So that most of the children can benefit from Dr. Salter's procedure, where the acetabulum has not opened up and an arthrogram has a normal contour in the cartilage condition. If, however, the acetabulum has been deformed secondary to lateral migration or ironing out of the roof of the acetabulum, the Pemberton procedure is more valuable and probably needs to be done in approximately 15 to 20% of this type of condition. In the child that's older, or maybe even a young adult, the previously two described procedures have not been as helpful as for the younger child. First of all, with the Pemberton, if the child is over 7 or 8 years of age, by deforming the acetabular roof, the risk of stiffness is very great and therefore a contraindication. Also, if the child is approaching adulthood, one cannot bend the triradiate cartilage, and therefore the Pemberton procedure is contraindicated for this type of patient. Dr. Salter's procedure is hampered in that the rotation of this fragment is down on the symphysis pubis in its lateral coverage, and therefore it is very difficult in the young adult and an older child to mobilize this segment to produce the correction that is needed. And therefore the procedure developed by Dr. Howard Steele of Philadelphia has been helpful, wherein the cut is made not only in the area of the Salter procedure, but in the other pubic ramus and ischium. This requires a great deal more surgery, but has been able to mobilize the fragment and produce the coverage that is desired. The procedure can be considered for bilateral conditions, in that one side can be done and healed, and then subsequently the second side may be done. Also, if a small shelf can be added to the corner of the acetabulae, which can be discussed later, to be helpful in coverage of the femoral head. The Sutherland procedure can at times be helpful also. In this procedure, an osteotomy is made similar to the Salter procedure, but instead of producing a cut in the ischium, a cut is made close to the symphysis pubis through a Fannin steel incision. A segment of bone is removed, and it allows a mobility of this part of the pelvis. It does not have the same mobility as the steel procedure because it's a further distance from the acetabulum, and also it requires pin fixation normally across the symphysis pubis. This is difficult at times to do, and there's some risk of migration of the pins. The Sutherland procedure can be considered where only moderate migration of the fragment is needed, and it's felt that a Salter procedure cannot produce this mobility. But for the patient that has a significant deformity where cartilage to cartilage contact is desired, it is my feeling at this time that the steel procedure produces the best amount of coverage. The other procedure that has been developed is that by Dr. Epbright in Houston, Texas, Dr. Wagner in Germany, and Dr. Kamomura in Japan, in where an osteotomy is done just around the acetabulum itself. And therefore, with mobilizing this segment, it can produce good coverage of the femoral head. This procedure is hampered in the fact that it's rather difficult to perform because there are large vessels and nerves front and back of the hip, and it's very difficult to carefully do this procedure without some risk to these vessels. On this person, it shows that even though there's a marked dysplasia and subluxation, the head is still quite round on the arthrogram. And this procedure was accomplished where the dial osteotomy, as Dr. Eppright calls it, mobilized the acetabulum and produced excellent coverage of the femoral head, and subsequently by moving the greater trochanter distally, it produced good mechanics of the hip. However, there is a slight narrowing of the joint space, and this other patient, 6 years post-operatively, shows a significant narrowing of the joint space. I am concerned at this time that this procedure runs a risk of producing some changes in the articular cartilage in the acetabulum. So this procedure not only being difficult to do, but with a biological risk that is damaging the articular cartilage from probably loss of blood supply to some degree because of mobilizing this large fragment of bone on a very narrow capsule, I believe that this procedure should not be conducted except by those few people who have had a large experience in the problem. However, there's been a great interest in the past number of years on the acetabular side, but one should also consider the femoral aspect of the problem. When a child has a residual dysplasia or a mild subluxation, it must be recognized that there's deformity on both sides of the joint, acetabulum and the proximal femur. And if both are approximately equally involved, one can consider a procedure on either side of the joint with the thought that the other side should recover from good centering of the femoral head. And in this particular patient, a proximal femoral osteotomy was done. Again, with a proximal femoral osteotomy, it should only be brought down to a low normal value, not to a pathological 90 degrees. And probably 115 degrees is the lowest that this angle should be reduced. And in this patient, with only a proximal femoral osteotomy, the femoral head was well seated, the acetabulum recovered, and came along very well. So that for the milder condition, especially up to 3 or 4 years of age, the femoral osteotomy can be considered as an alternative to the other procedures. But whatever procedure is done on whichever side of the joint, if the hip does not recover fully, one should consider going on the opposite side and completing the job. The procedures that I've outlined to you require that the femoral head be able to be seated deeply within the acetabulum. This requires that on an abduction test, where the femur is placed in abduction and in some degree of internal rotation, that the femoral head can be deeply placed within the acetabulum. If the femoral head will not go deeply within the acetabulum, these procedures should not be conducted because they require cartilage-to-cartilage contact. This is such a patient at 3 years and 9 months showing a significant deformity of the proximal femur with some changes in the blood supply of the femoral head and an abnormal acetabulum. On abduction testing, it shows that the femoral head goes deeply within the acetabulum. However, it does demonstrate that it requires considerable abduction to produce this result, and it shows a significant deformity of the acetabulum. An arthrogram at the same time could be helpful in helping this determination. But it's important for those procedures mentioned that there be good centering of the femoral head if an adequate result is to be obtained. For the patients where it is not possible to produce a good concentric reduction of the femoral head, some type of salvage procedure is in order. The procedure of Chiari, where an osteotomy is made above the acetabulum and then pushed medially and take the capsule into the interposing space, has been helpful. It requires, as demonstrating on this model, that the distal fragment go medially. And therefore, in order to accomplish this, the osteotomy must be somewhat upwards. There will be medial displacement of the distal fragment. And this leaves material above the head, that is the capsule. It is not ideal in that it is no longer normal cartilage to normal cartilage, because at best, this will change to fibrocartilage only. So that if one can carry out one of the previous procedures, this should be done rather than resorting to a Chiari, which is less of an ideal procedure because of the no longer cartilage-to-cartilage contact. A patient, however, who would benefit from the Chiari procedure is shown here, where there's a very large femoral head that even on the abduction test will no longer re-enter the acetabulum. On the lateral view, it is shown there's a very large femoral head and there's not an adequate acetabulum to receive it. By carrying out a Chiari procedure where the distal fragment is moved medially, one can have good contact between the femoral head and the acetabulum, but there's only fibrocartilage at best in here. This has been done in this particular patient approximately 15 years, and she has a very satisfactory result at this time. And it does look as though the Chiari procedure is a reasonable one for a young person that will last maybe 15, 20, 25 years, but will not be a long-term procedure. But probably in this day and age, knowing the shortcomings of other procedures, this is one certainly to consider very highly in people who have an uncovered femoral head, who are up into their early middle years and can allow covering of the femoral head and many years of wear. If there's a significant deformity in the neck shaft angle, one should consider reestablishing this angle before carrying out Professor Chiari's procedure. This was Professor Chiari's thoughts. It has been forgotten at times and may be the cause of failure of some of these procedures. So a normal, essentially normal neck shaft angle is rather important. Also, to maintain the position, a pin can be placed across the fragments or a screw to hold them rather than counting on a cast. And by using a pin, early mobilization of the hip can be started because stiffness is a consideration at times. So with the ideal considerations, the Chiari procedure can be very beneficial for the person that has an uncovered head that cannot be placed back deeply in the acetabulum. The shelf procedure was the original procedure where a shelf of bone was built out over the femoral head and lateral to the acetabulum. It fell into disrepute because of so many more sophisticated procedures that came along afterwards in the 50s and 60s and 70s. However, a reevaluation of this procedure shows that many of them that were carried out 30 years ago have worked out very well. And many of the patients can probably be reconsidered for this type of procedure. Such would be an early adolescent where the hip is reasonably stable but cannot be placed deeply inside the acetabulum because of the secondary deformity of the acetabulum. In this condition, a bridge of bone can be built out over the femoral heads. And this is a young lady who had her procedures approximately 18 years ago, who is doing very well and no longer has symptoms. And therefore, it would appear that this procedure has a larger place than it has been recognized in the past number of years. However, if there's significant instability of the hip, it will not prove satisfactory. Also, the shelf must be placed at the right level. There's been a tendency to place the shelf too high. It will atrophy and be of no value. And I think the problem here has been that there's been a tendency to place the shelf at the very top of the capsule. And it is necessary to split the capsule along the edge of the acetabulum and place the bone in a pocket out from the very corner of the acetabulum itself. Techniques have been developed and can be looked at and can be very helpful to do this. But with a properly placed shelf in a hip that has a center edge angle of approximately 0, still has some stability, where the patient is starting to have symptoms, then a shelf procedure may be better than a Chiari. It takes less time to recover from it and seems to produce the same coverage. However, I would suggest that patients that are adolescents to young adults that are having no symptoms and have only X-ray changes, that one should not carry out either a shelf or a Chiari in this particular condition, but wait till there's some special reason and special problems. But the key to the shelf has been to place it at the proper level so that the capsule can be split and the bone packed inside the split in the capsule so that one does not end up with a shelf up here and be embarrassed and be of no value to the patient whatsoever. Cup arthroplasty was well known many years ago. It is possible that many people will have to learn to do some type of cup arthroplasty again to treat these young people now that we know a total hip arthroplasty is probably not ideal for the adolescent and young adult. And for the patient that has unilateral hip disease, that has a complete destruction of the hip, and a normal hip on the other side, the hip fusion, much as we like to avoid it in the past years, is probably the most desirable treatment method for this group. Moving on now to the area which is really of most interest, and the chance to really prevent conditions and to reverse minor deformities, one has to go back to the newborn. Because in recent years, it's become apparent that the younger the child can be treated for a congenital dislocation of the hip, the better the result one can anticipate. And really, the golden period to treat a congenital dislocation of the hip is in the first 2 weeks of life. We thought for a while it was possible to diagnose all children during the first 2 weeks, but it's known now that many of these can be missed during the first 2 weeks of life, or that the problem doesn't exist. It is not an easy evaluation to make, and there's still problems where it is not recognized early and goes on and needs care later. The classic method to tell whether a hip is unstable in dislocated position to be reduced is the method of Ortolani, where with fingers the hip can be raised up and placed back into the joint. The problem here has been there's been a tendency to use too much force. This method should be done with great care, with just the fingers of the hand doing the lifting of the hip and pressing under the trochanter and raising it up so the hip will be reduced. The other method of Barlow, where the hip is in the joint at the time of recognition but can be easily pushed from the joint by adducting the hip and then pushing the hip gradually out of the joint. This is a dangerous test if done with too much force, but can be done rather gently with just the weight of the fingers and the hand. Adduct the hip and let the hip fall out of the joint. If it falls out of the joint, it suggests that it's grossly unstable and should have some form of treatment similar to the hip that's recognized as dislocated and can be placed back in the joint. At times, it is difficult to make the diagnosis in the newborn. One of the main problems, as I recognize it, that if the child is crying, one cannot carry out a proper examination of the hip. With the strength of the muscles around even a newborn's hip, it is impossible to make the determination of whether an Ortolani or a Barlow test does a positive one exists. So therefore, if the child is crying, one must return and repeat the examination at another time. The other problem is that many senior surgeons are still evaluating the child for tightness of the adductor. It must be recognized that tightness of the adductor is not a common thing in the newborn and only occurs in approximately 7 or 8%. And that most times, even if the hip has the potential to dislocate or it is dislocated, it will return to the normal position with abduction, and there'll be no limitation of abduction. If there is some limitation of abduction, it should be a sign to look very carefully at the child's hip. But if it does not exist, it is no indication that there is not a dislocation of the hip. It also requires a considerable time in developing the experience to properly perform an Ortolani and Barlow test, which means that one must examine many patients. However, of late, a model has been developed which is very good, which can help educate people and train them in the feel of the Ortolani and Barlow. And I would suggest that this be used more than it has been in the past to educate people on an ongoing basis to find the dislocations of the hip by having a higher index of suspicion and higher capabilities of feeling the deformity. As we've evaluated children over the years with the newborn, it's become apparent that there are certain profiles or certain groups of children that are higher risk. Anything that produces an abnormality of the child within the uterus seems to increase the risk of congenital dislocation of the hip. And the one that's the most important and the most obvious at times has been that of the female breech child, in that 1 in 35 children that were females and born by breech have a dislocated hip. And this is so much higher than in the general population that any time one recognizes that a child was a female born by breech, that special considerations be given, and the child should be rechecked on several occasions to be sure a diagnosis of dislocation of the hip was not missed. And that 1 in 15 have some type of instability of the hip. That if no other group is examined with great attention, if special attention is paid to the female breech, it will reduce the delayed problems to a great degree. Also, the patients with torticollis. 1 in 5 children that have torticollis have something the matter with their hip. As a rule, torticollis is not recognized in the newborn nursery, but is recognized in the first few months of life. So that any time a child is referred with the problem of torticollis, a very careful examination of the hip should be carried out to prevent deformity there, which may be more important than the torticollis itself. Also in children with foot deformities, metatarsus adductus have about a 10 times increase over the normal hip problems. And also the calcaneovalgus foot can produce an increased risk of hip dysplasia. So that when one is looking at deformities of the foot, one should think of the possibility that it was an associated deformity in the hip that may be rather subtle, but a special examination should be carried out on the hip to see that there's not another problem there that's very important. X-rays have been relied on by orthopedists for so many conditions that it's been felt that this was one way to diagnose congenital dislocation of the hip. X-rays have not been very helpful in the newborn. If the X-ray only is to be counted on, at least half the children will be missed that have a congenital dislocation of the hip. So if the test is positive, it's been helpful. If it's negative, it will mean that many have been missed. So one should not rely on X-ray signs alone in the early treatment of congenital dislocation of the hip under a month of age. However, interestingly, by the time the child is 3 to 6 months of age, if the treatment has not been instituted, almost 100% of them will show some X-ray changes. So that as the child gets a little older, the X-rays are very helpful, but in the newborn should not be counted on. A change should be made in the consideration of using extra diapers for the child with a dislocated hip. If a child really, truly has an unstable hip, this is not adequate treatment for most children, in that it has a tendency to hold the normal hip out and leave the one that is affected down in relative adduction and extensions. If there is a little concern, but no real proof that there's a dislocation or subluxation, one might use this method for a few days just to make a secondary analysis. But if a true instability of the hip exists, this is not considered to be adequate therapy. In the next group, where the child is a little older and has not been recognized, this is what we've come to call the intermediate hip. It's not perfectly normal, but it's not all the way out of the joint. It either represents a significant subluxation or a very early stage of dislocation. If the epiphysis is present, then one can help make the determination easier on the plain X-ray. But whether there's a severe subluxation or a minor early stage of dislocation probably doesn't make too much difference in the treatment of these patients, because it's been determined that by different degrees of flexion, one can reproduce the position of the femoral head towards the acetabulum. Here's such a child that with the hip not flexed up to 90 degrees, it shows that the femoral head is pointing proximally. If it's flexed too much, way up into the axilla with the knee, then the femoral head is too low as compared to the other side. If it's flexed approximately 90 degrees or a little bit above, it will redirect the proximal femur towards the acetabulum. And usually in the younger child, by holding the hip in this position, most of them will go back into the joint and end up with a satisfactory result such as this. The position that's been the most helpful to redirect the proximal femur back towards the acetabulum has been the use of the Pavlik harness, in which the stirrups have produced the desired flexion. One must be careful, however, in not tightening the posterior straps to produce too much abduction, but by thinking of it more as a stirrup that will produce flexion, and that the posterior strap only limit adduction, then one can redirect the femoral head in the anteroposterior view in most of the younger children back towards the acetabulum. And in our experience, up to 6 months of age, 86% of the dislocated hips have been reduced in this technique. But it must be remembered that this is only for children up to 6 months of age. The Pavlik harness is not beneficial for children much over this age, in the very rare exceptions. So it's important, however, to document the reduction. In the anteroposterior view, one can tell if it's pointed towards the triradiate cartilage, the proximal femur. If the femoral head is a little wide when it's first placed up, that's probably not too significant, because in a short period of time, usually within 10 days, 2 weeks, this will reduce down into the corrected position. However, if on the X-ray it's apparent that the hip is too close, it will mean that it's displaced posterior. And the concern in this group is that the femoral head can be reduced back behind the acetabulum, as is shown on this illustration, where the femoral head is behind the acetabulum, which is a great risk because it can produce a secondary deformity of the acetabulum, rolling the lip of the acetabulum forward. It appears that in the children up to 6 months of age, one can give a trial of a Pavlik harness for approximately 2 weeks without any great risk of producing this deformity. But this should not be persistent. One should have some proof that the femoral head is in the acetabulum, or discontinue the methods and go to other closed treatment programs. One of the ways to determine whether this is existing is palpating the trochanters on both sides. If feeling posteriorly, one can feel the trochanters of both hips equal. As a rule, the femoral head is in the acetabulum. If after 2 weeks there's a great prominence of the trochanter on that side posteriorly, the treatment should be abandoned. Lateral X-rays have not been very helpful in most people's hands in telling the position because so much cartilage exists. A new technology of ultrasound is coming along that's being very helpful to determine not only the contour to some degree of the femoral head and the acetabulum, but can tell us, especially in the lateral view, as to whether or not the femoral head is in the acetabulum. And I believe that this diagnostic method will be used much more in the future and should be encouraged to determine if the femoral head is in the acetabulum or out posteriorly. Because to reinforce the point that if the femoral head is left posteriorly, it will produce secondary deformities that are very significant. Another way to determine in the young child whether the femoral head is actually pointed into the acetabulum or maybe posterior is after a few weeks to take a set of X-rays up at 90 degrees and then down at approximately 45 degrees. If the femoral head points to the same spot in both views, one can be reasonably certain that the femoral head is directed in the acetabulum and is a reasonable secondary way to evaluate the process. However, this is not helpful until there's been some stability maintained, and the second X-ray should be taken only down at 45 degrees, not all the way down to neutral, and produce a secondary dislocation. One thing that's been noticed in the past number of years, especially by Dr. Paul Griffin from Boston, has been the evaluation of the hip on the opposite side. At times, there can be an abduction contracture of the opposite hip, which malaligns the whole pelvis, and with the involved hip may be getting worse. If one starts out on a treatment program for a subluxation of the hip and recognizes with time that the subluxation may be getting worse, this may represent an abduction contracture of the opposite side. If this child, for instance, should be treated in a Pavlik harness or any type of abduction device with this existing, then the further abduction here will increase this malalignment. If this is recognized, then treatment should be given to bring this hip down into the neutral position with stretching exercises and maintaining this hip, the involved hip, in some type of abduction device on its own. This is not a common condition, but it's common enough that if the hip is not doing well, the opposite hip should be particularly evaluated to be sure that it's not the problem. If the child can be diagnosed in the first month of age, usually the treatment program can be very short and only a matter of a few weeks. And in our evaluation, when the child was diagnosed under a month of age, it took only approximately 2.5 months for everything to return to normal. And it usually means that any type of abduction treatment can be discontinued after 6-8 weeks if everything is going in a normal fashion. However, interestingly, if the child is only 3 to 6 months, it takes almost a year for the bony architecture to return to normal. So if one misses the diagnosis for some reason or other, either it was missed in the testing or it was a late dislocation, one should be careful and follow these children very carefully for many months and a few years, because even at few months of age, it takes a long time to recover and may need continuous treatment of some type of abduction to cause a reversal of the program. If the child does not respond to the treatment as outlined, the Pavlik harness in the intermediate age, or it slips by in the early infancy, then a closed reduction needs to be considered. And one knows at this stage that this is a significant problem. This child is 10 months of age and is just recognized as having a dislocation. It is high and tight, and the femoral head is there, but it's not as large as it is on the opposite side. And most people realize that this child needs preliminary traction to pull this back down to some degree, to loosen the tissues, so that as this is placed inside the acetabulum, there's no increased force and reduces the risk of avascular necrosis. However, many people do not realize that this one is just as important, that a closed reduction should not be carried out on this much smaller child. It's easier to do, it's easier to force it back, but the risk of pressure from doing this is greater probably in this child, and the risk of avascular necrosis is greater in this child than it is in the somewhat older one. And I think it's fair to say that there's a risk in all these children, especially the young child, where there's very little bony nucleus or none, that these vessels can be squeezed either inside the femoral head or wrung out in the capsule. And probably the direct pressure in these young children is more important than what happens to the capsule itself. So I think it's fair to say that no closed reduction should be attempted without an adequate traction program preliminary-wise to pull the femoral head back down to its proper level and to reduce the pressure. Traction can be done in one of two ways. The classic way has been to have the child in the hospital for a period of time. But this day and age, with the concern about hospitalization, and it's a difficult problem. Also, it's a very rare occurrence in most hospitals, and most people don't know how to apply traction very well. So we have gone to a home traction program where we've made up a frame, had the child be treated on this frame at home with varying degrees of weights. Most of these little children can stand 3, 4, or 5 pounds of weight without any trouble. The program can be conducted by either the mother or the grandmother, and the child can be brought back to an institution or to a private office and have an x-ray on the frame to see if the hip is coming down into position. It also takes the pressure off the whole problem, and that they can wait for 2 or 3 weeks and produce the traction rather than the pressure that's on if the child is in the hospital to have the treatment accomplished very quickly. And it's been a very good program in our experience, and we've treated over 100 children by this technique to date. The other change has been the concept that with closed reduction, that there is a risk that the hip can drop back out of the joint again. Many years ago, it was thought that all the children should be placed out at 90 degrees, but this resulted in a high risk of avascular necrosis, even if preliminary traction has been applied. And the safe zone, as developed by Ramsey, has been very helpful in that a determination is made between what is the abduction to reduce the hip and how much adduction the hip can be placed in before the hip redislocates. If this zone is very narrow, then an adductor tenotomy, a closed adductor tenotomy, can be accomplished to take the tension off the adductors and increase this safe zone so that the amount of abduction between what can be tolerated and what redislocates, it can be increased to a great degree. However, the danger here is that one will take advantage of this full zone and place the hip out in the too much abduction. Once this safe zone has been determined, it's probably wise to place the hip somewhere in the middle of that zone because there's certainly other structures tighter inside as well as just the adductors themselves. So the middle of the safe zone is probably the most desirable to reduce the risk. And so a child should rarely if ever be abducted more than 50, 60 degrees. There should be a lot of flexion, because flexion is very important in these young children to produce a good redirection towards the acetabulum. And probably the knees should be in a little more than 90 degrees of extension, because these children grow very rapidly and can be accommodated much better if they can slide down in the plaster to some degree. Also, the feet can be left out because there's no reason to produce pressure around the foot. The big risk, however, is avascular necrosis. Here's such an example. Here's a young child that has the most a mild to moderate dysplasia and subluxation, who was taken to the operating room, put under anesthesia, and had closed reductions bilaterally. In so doing, the follow-up at 2 years and 10 months showed that both femoral heads and necks have been pretty much destroyed. And there's no way that this can be reversed. Now, it is true that most people would not apply this much force, but it does not require very much to have this occur. Here's a child that had the hip so-called popped back into the joint very easily, and a cast applied, but with a little bit of force apparently. And here the child is, sometime after removal from plaster, showing that there's only mild changes. There's a little change in the vascularity of the femoral head. There's still a little acetabular change. But the important thing is that already it looks as though the neck is a little short as compared to the other side. And at skeletal maturity, this child does not have a normal hip. You can state that there's overgrowth of the trochanter, and this can be corrected by mobilizing it and replacing it on the lateral side. But also it's to be recognized the head is not round, the neck is short, and the acetabulum is not cupping the femoral head in a normal way. In other words, the epiphyseal line was disturbed at the time of the closed reduction, and once the epiphyseal line closed early, then there was no longer biological stimulation to produce a normal hip. And this child with a very minor problem has ended up with quite a major problem at this time, with shortening of the leg, overgrowth of the trochanter, and less than a normal development of the femoral head and acetabulum, and will certainly have a continuing series of problems as he goes along through life, which could have been avoided by preliminary traction and careful reduction in most cases. However, avascular necrosis cannot be entirely eliminated, even with the best of treatment. There are always a few, but the hope is it will not be a serious form. Avascular necrosis can be divided into different groups, where there's only a little involvement of the femoral head, and this recovers as a rule, where there may be some involvement of the epiphyseal line and produce a deformity of the femoral head in relation to the neck, showing that these children need to be followed through their full growth period, where the one, as I just showed you, that involved the epiphysis but also involved the epiphyseal line and produced a short neck, and the very serious form that I showed you first, where there's complete deformity of the femoral head and loss of the growth plate. And all of these have a very significant concern. If there's any avascular necrosis that's produced, it has a great risk of causing trouble. And one cannot determine the full extent of the problems, such as these two, until much later. So anything that can be done to prevent unusual positioning, the preliminary traction to loosen it, all this should be done with great interest in reducing the risk of avascular necrosis. I would suggest to you that it's ideal to treat the child in the newborn phase. Many of the children, however, are not diagnosed at this stage and are picked up some few weeks to a few months later. These must have a reduction done with great caution, because the risk of producing avascular necrosis is quite high and is the major problem in the child under 1 year of age. If the hip cannot be reduced, it can be done later by another technique. But if avascular necrosis is produced, it is a significant problem that will, in many cases, last as a problem throughout the child's life. In summary, then, the problem of congenital dislocation of the hip in the child that's been recognized after walking stage is that really of the treatment of residual subluxation in an effort to obtain as ideal conditions as possible, but probably not a completely normal hip. In the young child under walking age, the problem is that of avascular necrosis. and this should be avoided if at all possible.
Dean, can congenital dislocation of the hip always be discovered in the young child? And if treated early, is the result always successful?
Well, that's a very important question, Jack, because for a while there was a feeling that they all could be picked up in the newborn nursery. I think there's several considerations. One is that the person may not have the experience to always diagnose it, but even in the best of hands, there's certainly some that cannot be diagnosed even though the problem may be around at that time. There's also very definitely a group that have dislocated or subluxated after the newborn phase, so that it's not always possible to make the diagnosis. I think the only thing that's demanded of a clinician at this stage is that somebody actually do the exam and record that they've done it in a reasonably proper way. Also, all the children that are diagnosed in newborn cannot be treated with success at that stage. There's a certain group that are teratologic, that were dislocated before birth, that are very difficult to handle, but are the exception. But even the classic dislocated hip that can be recognized in the newborn may not be successfully treated at that stage. There's one group that are so lax, that are almost like an Ehlers-Danlos type of child, that have so much instability that they cannot be stabilized at that stage.
If a young child is fitted with a device in the treatment of congenital hip disease, Dean, how often should he be reevaluated?
It's very important that he be followed frequently. There's been a tendency to apply a device and think the device is going to do the job and not check for several weeks. It must be remembered that the hip is unstable and may not stabilize properly in the device. So the child should be seen if there's real concern after 3 or 4 days, and certainly as long as there's a problem of instability, the child should be seen probably at least at weekly intervals.
When you're treating a child with congenital dislocation, how important is the consideration of antiversion and its changes?
Well, it must be remembered that antiversion is a natural phenomenon, and there's an increase in the young child over the older one. As a rule, as a kind of a blanket statement, if the child has a true reduction and there's only dysplasia and there's no concern of subluxation, that probably antiversion is not a significant concern. However, if there's subluxation, at times the antiversion and the valgus that are associated, apparent valgus, is the area to treat, especially if the acetabulum has been developing in a relatively normal way.
Dean, is a CT scan helpful to you in analyzing the relationship of the femoral head to the acetabulum?
Yes, Jack, it is, especially after a reduction. To see whether or not the hip is deeply reduced, it has been very helpful. However, many times, if there's really a frank dislocation, it can be discovered by simpler and cheaper methods. But for where there's a real concern, it can be helpful. It has not been as helpful, though, in the very young child, because it's better at showing the bony alignment than the cartilage.
Is it ever advisable to avoid treating the patient with bilateral dislocated hips?
I believe that there are times when a child with a bilateral dislocation of the hips should be left alone. Certainly in children over 3.5 to 4 years of age, one can anticipate great problems in the reduction at times. And only those with a great experience should probably attempt the reduction after this age. If a child has attempts at reduction and they're not very successful or unsuccessful, the child is much worse off than they've never been touched. And I think some of them are better left alone.
Thank you, Dr. McEwen. And for the last presentation of this issue, Dr. Isidore Yablin discusses treatment of malunited ankle fractures. The reduction and stabilization of ankle fractures is essential to normal function. Isidore, how do you deal with the problem when these goals are not met?
The problem is essentially a malunion of the ankle. The malunions can be classified into the occult and overt types, which I shall discuss in a few moments. But basically, when we have a problem of malunion, it means that the ankle has not been reduced properly to begin with. And this goes back to about 1977, when we first published some of our results in dealing with displaced and unstable ankle fractures. What we did at that time is we ran a number of experiments to determine whether the medial or lateral side was more important in providing stability to the ankle. We found that the lateral side was more important because if you divided the lateral malleolus or the fibular collateral ligaments, there was much more talar instability than if the deltoid ligaments or medial malleolus was divided. Following that, we concluded that in order to anatomically reposition the talus, it was necessary to anatomically reduce the lateral malleolus. And the reason for that is that the talus faithfully follows the displacement plane of the lateral malleolus, so that any residual displacement of the lateral malleolus will account for some residual displacement of the talus. If, however, the talus is anatomically repositioned, despite the fact that the lateral malleolus is not reduced, some slight talar instability will occur. And because of this, there will be a predisposition to the development of late degenerative arthritis. If there is incomplete reduction of the lateral malleolus, then a malunion will result. Malunions of the ankle can be classified in the occult and overt group. In the occult group, the talus is in or near its anatomic position, and these are very difficult to diagnose. Here is a radiograph showing the talus in a relatively normal position. It would be difficult in this case to determine that something was wrong. However, patients at this stage are symptomatic. In the overt type, the talus is visibly displaced, and it is not too difficult to make the diagnosis. In this radiograph, one sees widening of the medial joint space, and one does see early degenerative arthritis beginning. And here there is some mild lateral displacement of the talus. This then would be the overt type. The diagnosis is made by obtaining good quality AP and lateral radiographs, lateral tomograms, and a CT scan. In almost all instances, the diagnosis can be made on the lateral radiographs, which show a residual displacement of the lateral malleolus, indicating that this was not reduced anatomically to begin with. Where there is doubt, lateral tomograms and CT scans are of value and can help make the diagnosis. The common findings is that the lateral malleolus is incompletely reduced in a patient who has pain over the anterior aspect of the ankle, and if careful examination is performed, there will be tenderness over the anterior tibiofibular joint. Here is a lateral radiograph showing incomplete reduction of the lateral malleolus. This patient sustained a bimalleolar fracture. Attention was paid only to the medial malleolus, which was reduced, but the lateral malleolus was not completely reduced. This then results in a subluxation of the distal tibiofibular joint. Here is another example of incomplete reduction of the lateral malleolus. Because of this, and because the talus will follow the displacement plane of the lateral malleolus, there is incomplete reduction of the tibiofibular joint, which is the cause of symptoms. It is this subluxation which accounts for the pain and the swelling, and unless the anatomy of the anterior tibiofibular joint is restored, the patient will continue to complain of pain. If he is an athlete, his endeavors will suffer, and he will not be able to perform at maximum capacity. This is an intraoperative photograph showing the pathology. This is the lateral malleolus. An osteotomy has been performed here, and I'll explain the importance of this in a moment. But what I would like to direct your attention to is the subluxation of the distal tibiofibular joint. This is the incisura of the distal tibia against which the lateral malleolus articulates. Note the widening and the external rotation of the lateral malleolus. And this is basically the pathology. In treating these malunions, two principles must be achieved. The first is to osteotomize the lateral malleolus, and the second is to pull the osteotomized malleolus distally and internally rotated. This is demonstrated in this particular intraoperative photograph. An osteotomy has been performed of the lateral malleolus, and it has been cleaned of scar tissue and also separated from the interosseous membrane. This is the subluxation of the distal tibiofibular joint. It is helpful if a unicortical drill hole is drilled posteriorly into which is inserted a bone hook. At this stage, when the lateral malleolus has been mobilized, it can then be pulled distally and internally rotated to restore the integrity of the tibiofibular joint. In overt malunions, additional surgery is required. In these instances, the talus is visibly displaced, and it is displaced in a lateral direction. In order to reposition the talus, it is necessary to remove the scar tissue on the medial side, that is, in the area between the medial malleolus and between the medial side of the talus. A separate incision must therefore be made over the medial malleolus and the interval between the medial malleolus and talus entered into. This allows for the removal of scar tissue, and after this has been achieved, the talus can be displaced laterally to resume its anatomic position. This is an operative photograph. This is the medial malleolus, this is the talus, and this is the shoulder or tibial plafond. Note that the talus has been repositioned against the medial malleolus, and its lateral displacement has been corrected. This can only be done by the removal of scar tissue in the area between the talus and the medial malleolus. Once this is achieved, the talus can be manually repositioned, and it is very helpful if a Steinmann pin or stout K-wire is drilled through the tibia into the talus. This secures the reduced position of the talus and frees the hand of the surgeon to proceed with the surgery. Now, the continuation of the surgery, once this is achieved, is to pull the lateral malleolus distally and internally rotated, and when that has been achieved, internal fixation is done by applying a 6-hole plate. We recommend a plate because this will secure the lateral malleolus and, in addition, will prevent rotatory displacement, which can often occur if other means of internal fixation is used. Also, because the interosseous membrane has been divided in mobilizing the lateral malleolus, it is essential that a syndesmotic screw be used. Now, it doesn't matter whether the syndesmotic screw is placed through the hole of the lateral malleolus or through the distal hole in the plate of the fibular shaft, as long as one remembers to use a syndesmotic screw in order to allow for healing of the syndesmotic ligaments. It is important not to be misled by the near or anatomical position of the talus on AP radiographs in an individual who is symptomatic with regard to his ankle. In all instances, these patients complain of pain. The pain starts when they get up in the morning and progresses as they become more active. Ultimately, as stated previously, their athletic performance is interfered with, and they will develop, over the years, degenerative arthritis. This is because they have some residual mild talar instability, and they have a subluxation of the distal tibiofibular joint. The aim of treatment is to restore the anatomy. If the talus is displaced, that must be repositioned. And if the lateral malleolus is incompletely reduced, it must be completely reduced and restored to its anatomical position, and that is done by achieving the original position of the tibiofibular joint. Again, here is an intraoperative photograph showing that the lateral malleolus has been osteotomized. A unicortical drill hole has been made in the posterior cortex of the lateral malleolus. A bone hook has been inserted, and the lateral malleolus has been pulled distally and internally rotated in order to reduce the subluxation of the anterior tibiofibular joint. Once this has been achieved, the 6-hole plate is applied. In some instances, the plate must be contoured to fit the shape of the lateral malleolus. We recommend that a 6-hole plate be used because this affords the most rigid internal fixation, and it is important to remember that one of the screws has to be a syndesmotic screw in order to allow for healing of the interosseous membrane. This is a post-operative radiograph showing the osteotomy, which has been performed at this level of the lateral malleolus, and indicating the application of the 6-hole plate and the use of the syndesmotic screw. There are 2 contraindications to the performance of this type of surgery. The first would be loss of bone stock between the talus, the distal tibia and the lateral malleolus. The second would be the development of degenerative arthritis. It is therefore important that the diagnosis be made before arthritis manifests itself so that the patient may derive the maximum benefit from this operation. These are radiographs which demonstrate an overt malunion. One can see in this AP radiograph medial joint space widening between the talus and the medial malleolus. This patient complained of pain, was unable to walk without a limp, and surgery was considered because degenerative arthritis was not too far advanced in this instance. The lateral view shows the true pathology, which is an incomplete reduction of the lateral malleolus. This in turn would lead to a subluxation of the distal tibiofibular joint. Let us now take a look at the operative technique and see how we actually reduce this subluxation. The incision is made along the lateral malleolus and is outlined here. This is the tip of the lateral malleolus, and my finger is indicating the extreme end of this bone. Full thickness flaps are raised and should be brought right down to bone. It is not recommended that any subcutaneous dissection be performed. This will help in the post-operative healing of the skin. The dissection should also be carried anteriorly. The reason for that is that the interosseous membrane must be exposed, and this will lead directly to the distal tibiofibular joint, which contains a great deal of scar tissue, and this must be resected. It is recommended that sharp dissection be used. The bone is osteoporotic, and there is danger of fracturing either the tibia or fibula if vigorous use of a periosteal elevator is employed. Now here, the interosseous membrane is being exposed, and the distal tibiofibular joint is coming into view. One also wants to identify the old fracture, and here one sees the original fracture and the malunion of the lateral malleolus, which is healed in a shortened and externally rotated position, giving a widening to the distal tibiofibular joint, as can be seen here. If the fracture line cannot be identified, then a transverse osteotomy is made about 7 centimeters proximal to the tip of the lateral malleolus. In this case, however, one can identify the fracture site. Now, an incision is made over the medial side because this is an overt malunion, and there will be a great deal of scar tissue between the medial malleolus and the medial aspect of the talus. This is removed, following which an osteotomy is performed on the lateral side. This is generally done with an air-driven oscillating saw. After the osteotomy has been completed and the scar tissue has been resected, the talus can be mobilized. And this is facilitated by the drilling of a unicortical drill hole in the posterior cortex, as will be seen shortly. Following this, the talus is manually repositioned on the medial side and brought into close abutment against the medial malleolus and the distal portion of the tibia. It is then held in place by the introduction of a K-wire, and we're just now completing removal of the scar tissue between the talus and the medial malleolus. It is recommended that once reduction of the talus has been achieved, that the Steinmann pin be drilled from the tibia into the talus as previously shown. At this point, an intraoperative radiograph should be obtained to check on the position, and this is what you see here. Notice that the Steinmann pin crosses the tibia and secures the talus in its anatomical position. Once the surgeon has been assured that the talus has been adequately repositioned, a posterior cortical drill hole is made and the bone hook is inserted into the distal portion of the lateral malleolus. This enables an assistant to correct the subluxation of the anterior distal tibiofibular joint. The lateral malleolus is pulled distally and is internally rotated, at which time a 6-hole plate is applied. Although this is a compression plate, it is not necessary to apply compression because the fixation is very rigid in the way it's done here. The holes are drilled and tapped. The depth gauge is used to assure accurate depth, and the screws are inserted. During the time that the screws are inserted, the assistant holds the lateral malleolus in its reduced position, again by pulling it distally and internally rotating it. As mentioned previously, one of the screws must be a syndesmotic screw. It must go from the lateral malleolus into the tibia. The reason for this is that the interosseous membrane has been divided in mobilizing the lateral malleolus. If a syndesmotic screw is not used, there is a danger that a diastasis may occur after the external fixation is removed. For this reason, it is strongly recommended that such a screw be used. It is kept in place for about 16 weeks and then removed under a local anesthetic. Ambulation is not contraindicated when the syndesmotic screw is in place. Here, the syndesmotic screw is being inserted to go from the lateral malleolus into the tibia. This is a post-op radiograph showing the application of the 6-hole plate and the syndesmotic screw. It makes no difference whether the screw is inserted through the proximal hole of the lateral malleolus or through the distal hole of the fibular shaft as the screw is used. The segment which you have just seen deals with the treatment of an overt malunion. The following describes the operation for an occult malunion. This is the preoperative radiograph. Note that the position of the talus on first glance looks pretty good. It seems to be sitting in its anatomical position. On the lateral view, one sees the incomplete reduction of the lateral malleolus. This should alert the surgeon that there is a malunion and that this will also cause a subluxation of the distal tibiofibular joint. The lateral malleolus is outlined and an incision will be made along the midline of the lateral malleolus. Full thickness flaps are developed. One looks at the anterior tibiofibular joint, which is subluxated and can admit a periosteal elevator, and it is necessary to divide the interosseous membrane. This is the old fracture. It's an oblique fracture, and the osteotomy will be made at this point. In the occult malunions, it is not necessary to make an incision over the medial aspect of the ankle since the talus is not displaced. Here, one is dealing with simply a subluxation of the tibiofibular joint. An attempt now is being made to mobilize the lateral malleolus. A unicortical posterior drill hole has been made and the bone hook has been inserted into the posterior cortex. The lateral malleolus is being pulled distally and internally rotated. It is important to dissect all scar tissue so that easy mobilization of the lateral malleolus can be achieved. If this is not done, it will not be possible to reduce the subluxation of the tibiofibular joint. Again, it is recommended that sharp dissection be employed. It is important again to emphasize that as much scar tissue as possible be resected in order to allow the lateral malleolus to be easily mobilized. If the scar tissue is not resected completely, it will not be possible to mobilize the lateral malleolus, and therefore it would not be possible to restore the subluxation of the tibiofibular joint. One can now see that the lateral malleolus has been freed and that the tibiofibular joint is being restored to its anatomical position. Once the lateral malleolus has been mobilized, the 6-hole plate is applied and contoured if necessary. The drill holes are made using a power drill. The depth is ascertained and the holes are tapped. The screws are then inserted, bearing in mind that one of the screws, either proximal or distal to the osteotomy site, must be a syndesmotic screw, again for the same reasons as previously stated, namely that the interosseous ligament has been divided. Note here that the integrity of the tibiofibular joint has been restored, and that has been achieved by pulling the lateral malleolus distally and internally rotating it. It must be held in that position by an assistant holding the bone hook as the rest of the screws are inserted and fixed. Here, the syndesmotic screw is being inserted, and it goes from the fibula across the tibiofibular joint into the tibia. This is a post-operative radiograph showing the application of the plate with the syndesmotic screw. This is a lateral radiograph. Note that the fibular osteotomy is visible at this point. If the osteotomy gap is less than 3 millimeters, it is not necessary to do anything since this will heal spontaneously. If, however, more than a 3 millimeter gap exists, it is advisable that some bone be taken locally from the tibia and applied to the osteotomy site to act as a bone graft. In some instances, it may be difficult to see the malunion of the lateral malleolus on lateral x-rays or even on lateral tomograms. In such a case, the CT scan has proven to be very helpful. Here's an example of such a CT scan. They should be taken bilaterally. Note that on the right there is a normal relationship between the lateral malleolus and the talus at the distal tibiofibular joint. On the left, however, there's incongruity because the lateral malleolus has been externally rotated. This portion of the lateral malleolus should articulate with the incisura of the tibia. And this CT scan shows the subluxation very nicely and has proven to be of great help in those cases where it was difficult to make the diagnosis. After the operation has been terminated, a short leg cast or posterior splint is applied for comfort, and this is left in place for about 24 to 48 hours. It is also important that the extremity be elevated and that the ankle should always be at a level higher than the heart. This is best achieved by suspending the lower extremity from an overhead bed frame in a canvas sling. Active assisted dorsiflexion and plantar flexion exercises are started usually on the second day, and a special orthosis is fitted which only allows for dorsi and plantar flexion but does not allow for rotation. The patient then begins on graduated weight-bearing exercises and ambulation with crutches and can proceed to independent ambulation as soon as the patient feels comfortable. And this can occur anywhere between 2 and 3 weeks. As stated previously, the syndesmotic screw is not a contraindication to full weight-bearing and is removed under a local anesthetic at about 16 weeks.
Isidore, you have certainly clarified a problem that we didn't even recognize when we were residents. Why is it that the lateral malleolus is so important in the occult malunion?
I believe the reason for this is that we still think that the key to the reduction of ankle fractures is the medial malleolus, and as a result, we don't pay enough attention to the lateral malleolus. In the light of contemporary knowledge, I believe it is important to recognize this and to understand that the talus will follow the displacement plane of the lateral malleolus. If the lateral malleolus is incompletely reduced, there will be some residual talar instability and a subluxation, as demonstrated, of the anterior distal tibiofibular joint.
What is the best way of preventing both these occult and overt malunions?
I believe that one must pay attention to the lateral malleolus. I think one has to understand that the lateral malleolus is the key to the reduction of these unstable fractures. The basic principle here is if the lateral malleolus is anatomically reduced, I believe that the talus will be anatomically reduced as well, and that the ankle will heal uneventfully.
Some people believe that after the open reduction of ankle fractures, if you've placed a syndesmotic screw, you should not permit weight bearing. Have you had any problem allowing these patients to bear weight early?
None whatever. We've had quite a large group of patients who have had a syndesmotic screw applied, and we have encouraged early weight bearing. If anything, there will be some resorption in the area that the screw passes from the fibula into the tibia, but we have not had a single instance of screw breakage.
Isidore, you've stated that one of the main reasons for operating on these malunions is to prevent degenerative arthritis. How long is it before it's too late to prevent this arthritis?
I think basically this is a judgment call on the part of the surgeon. One has to carefully examine the x-rays and make the decision accordingly. If there is marked narrowing between the tibia and talus, if there is a great deal of osteophyte formation between the medial malleolus and the talus, then I think it is too late to offer the patient any benefit from surgery of this type, and I think that one should think of doing an ankle arthrodesis.
Isidore, I think it's important that you comment on your results with this procedure.
To date, we have done about 19 of these operations. Out of the 19, 8 were for occult malunions, and the remainder were for the overt type. There were 4 instances in which, although the patient showed an improvement in their level of activity, they did come to an arthrodesis within 3 to 4 years. And I believe this goes back to my previous answer, that it's a judgment call to decide when surgery is indicated. I think that in these 4 instances, things went a little too far and the patients were on their way to developing true degenerative arthritis. In the other cases, all patients returned to their former level of activity.
What's your length of follow-up, including your longest and shortest cases?
The longest follow-up has been a little over 7 years, and the shortest about 6 weeks. We are seeing about 3 to 4 cases a year now since we have discussed this problem and have offered a solution to it.
Thank you, Dr. Yablin. This concludes this issue of the Video Journal of Orthopedic Surgery. Remember, those of you applying for CME credit, fill out the questionnaire enclosed with this issue and return it promptly.